With,
Our recording. Okay. And then also Eventbrite. Be sure to sign up for our Eventbrite so that you're a follower and you get updates about upcoming events and future webinars as well. We've been doing our SickleSMART season from September all the way through now, December. And so you can go back and see some of these other topics that we've discussed each month. In December, after this, we will start our Smiling Through the Pain series. So we're very excited about that as well. Just want to remind you that Be the Match has come out with a new Sickle Cell Warrior resource package, which is super exciting. You can order your free package at sicklecellconnect.com. Order one for yourself, order one for someone that you love that's living with sickle cell disease. And if you are a provider, be sure to share this resource with your patients. Lots of great information, and it's a wonderful connection to the Be the Match organization to better understand how we can make a difference for those living with sickle cell disease. And then today's conversation, as I said, we are going to be talking transition with Dr. Alex Boucher, hematologist at mHealth Fairview. Now, this is going to be a conversation. If you've joined us for previous Living SickleSMART sessions, sometimes it is more of a presentation with question and answer at the end. But this time we want your participation. We don't want it to be a presentation. We don't want to talk at you. We want to talk with you. We want to talk about the good, the bad, and the honest conversations about transition. Have you already gone through transition? Are you going through transition? Are you thinking about your little one who will go through transition? What has worked well? What kind of things concern you? We want to hear that. Now, we did set up a couple of polls before we get started, so I'm going to launch this. We first want you to tell us, how are you connected to the sickle cell community? So we want to know, are you a sickle cell warrior? Are you a warrior caregiver? Maybe you're a medical professional. An educator, maybe you're a community stakeholder, maybe you're a family member, someone that just loves someone with sickle cell disease, maybe you are a friend of someone who lives with sickle cell disease. And then of course the other catch-all is other, but we want to know who you are. So, all right, we're going to give a few more minutes. Awesome. It looks like everybody has answered. Oh, more coming in. All right, one more. All right, I think this is my first time using polls, you guys. So this is somewhat trial and error. Let's see how this works, but this is awesome. Looks like, can you see this, Dr. Boucher? Can you see the results at all?
I cannot, no.
Okay, so I'm going to have to learn how to be able to show you all. I'll have to figure out how to show you guys the result. But what I want to say is that we have 14% of our attendees are sickle cell warriors, 7% are warrior caregivers, and 21% are medical professionals. We have 7% that are educators and 14% community stakeholders. 36% of you are other. I don't know what other means, but I'm happy that you're here. And we look forward to interacting with all of you. So, oh, there we go. Now it says share results. But okay, so we are going to move forward. That is our first poll question. And then our next poll question. It's not going to let me pull up my next poll question. My next poll question really has to do with where are you in your transition journey? So are you thinking about transition? Have you started transition? Have you already been through, or are you actively in transition, or have you already been through transition? So we just want to get an idea of where you are in that journey. But we think that everybody has something to offer to this conversation. So without further ado, how you doing, Lee? I see you. We are so happy to have you here with Juneteenth, Minnesota. But without further ado, let's have a conversation. I'm going to turn it over to Dr. Boucher. Please introduce yourself to our guests.
Yeah, thank you, Ray, for having me here. Thank you to the Sickle Cell Foundation of Minnesota and the sponsors. Ray and I have known each other for several years now, going back even before I left for extended training and came back. And so it's really a pleasure to be working side by side with the Sickle Cell Foundation on these efforts. So I am, as Ray said, one of the hematologists at the University of Minnesota. I lead our sickle cell programs on both the pediatric and the adult side. So I literally practice across that lifespan. There are very few of us who do that across the country, actually. Hopefully we have more in that space, but it's really important that, from my standpoint, that we do that because there's really different approaches to care in some ways on both sides, and I hope we can discuss that more here. But one of my missions is, when I was taking care of sickle cell disease, or even when I just trained in pediatrics and adults, I knew that this transition of going to the adult clinic and what is it going to look like is really anxiety provoking for anybody, but particularly if you have something like sickle cell disease where you've really needed medical care for your whole life. And then I found that this was really a passion of mine, more than just the care of it, but really how do we make it better? And when we think of what does that mean, it's really thinking more about what we call patient-centered outcomes, or what are the outcomes, what are the whether it's research or just clinical, the ways that are really affecting our patients, because I'm as guilty as anybody else of getting so into the research and finding really fascinating findings, but they don't actually matter on the day-to-day life for somebody with sickle cell disease. And so it's really told me, as I discuss with patients, what can I do on the day-to-day life to make things better? And how can we make this transition smoother, successful, and ideally healthier? That's the ultimate goal. So that's what I hope to talk about today.
Yeah, I'm actually really excited because, most people know that I am a caregiver to a young adult. And I I wish that there was this transitional word even for a caregiver, right? It's one thing to be a caregiver when your loved one is a child and you have the authority over them and somewhat over their body and the medical decisions that are made. But then when they turn into this adult and the decision making is theirs, you are still part of their team, right? But you're not necessarily that decision maker. It is a participatory kind of affair. But I remember, even though my son transitioned, it doesn't seem like 7 years. Gosh, how is it that everyone gets older and I stay younger? But there's been changes, right? Even from the time, my son is 25 now, even from the time that he transitioned when he was, I suppose 21. So it's been only 4 years. That's why I'm like, no. But there's been changes even then and then even prior to that. So I think what's important is that we continue having these discussions. And although some of us are at different places in that transition journey, we can not only take a look at what worked or didn't work when we went through it or were going through it, but also what has changed in positive ways. How has it become smoother? How has the handoff become more of a warm handoff than just a patient transfer? So that's what I love. I love the fact that the University of Minnesota, as well as other institutions across the Twin Cities, are now really looking at ways to do this more seamlessly so that individuals who are living with sickle cell disease don't feel this huge hiccup in their life. But the reality is, pediatric care is different than adult care. Let's talk about that a little bit.
Yeah, so when I think about pediatric care, I kind of equate it to a small town environment in the sense that really, for one, the hematologist is your primary physician in the most situations, or at least becomes that default. But two, it's a very kind of coalesced team, and patients and families and providers, they all know how to kind of, if there's a question about how to get somewhere or what kind of referral is needed, there's the extra hand, or in the small town setting, it's like you just ask the person at the grocery store counter, how do I get here? I'm not here, and somebody will do that. So you go from that aspect of care, and you do that same thing for 20, 21 years of your life, to what I would equate as sort of the Autobahn superhighway of medical care, which is adult medical care, because it's really built for those who develop diseases over their lifetime or who are in middle age. It's more of super highways where there's not really good off ramps. The off ramps don't have good signage. You're a little bit more on your own. That's the way it's built. And so that is one of the biggest challenges, and that I think leads in part to a lot of the challenges with transitions, is just that the healthcare models are different. And I don't think I really appreciated that until I really started doing it after training and splitting my time across those boundaries. So that's one of the biggest things, is it's just not pediatrics 2.0. It's a very different healthcare structure. And to some extent, maybe that's why there aren't as many people who do what I do, is because you do have to almost have two hats on at all times, unless you can really have a support system to combine those over the lifespan.
Yeah, that's exactly right. It's very interesting because on the pediatric side, it's like all of these different resource persons. They're like, resources are actually human beings, right? In pediatrics for the most part. And I feel like on the adult side, though there are resourceful human beings, it almost feels like those resources is more of a list, or let me refer you here, or let me tell you about this. And it's not necessarily the humans that come into your clinic room and they're like, okay, well, let's sit down and talk. It's not the annual comprehensive visit necessarily that you might be used to in your pediatric environment. And so there's a lot more legwork to not just figuring out who all is on your team, but actually getting some resources out of the referrals that you're given, or out of the information that you're given. And so that can feel like extra work if you're not used to navigating a system in that way, or you have the expectation that the system should be showing up in ways that, let's be honest, it is not currently designed to do, or at one point it was designed to do, but the system became so overburdened that now capacity wise, there's just not enough people to take care of all the needs. And that's hard, right? But that's also part of what complicates transition along the way, because it is those differences that show up that you're like, this isn't what I'm used to. So one of my questions is, how do you prepare for transition going into the adult healthcare system?
Yeah, that is actually one of the biggest things, I think, that when we talk about this adolescent young adult transitions, or sometimes I'll use the term AYA, realistically, I think for people in our field, we really push that out from about 18 to 25, maybe even 30, if we're looking at that, certainly in that 18 to 25 range. That's a lot of what the focus on, and there has been work for certainly over a decade and probably longer. And you know, my colleague and mentor Steve Nelson was a leader in this kind of field for many years around here. Was prepping the transition going back to essentially 10, 12 years old, and so the kind of trying to make it the norm to talk about what is it like to have sickle cell disease and how do you prepare yourself. The challenge there is that's just like the homework before the test. And you don't have that teacher on the other side of the test most often. And so when you actually have to come to that threshold, you've been climbing that mountain. In some ways, anxiety sort of gets built up with that too. And now you're at the top of that mountain. It is our job on the adult side to actually make the same sort of slope back down to sort of, you've been climbing up here, come back down in the same fashion. And it's not jumping off with a parachute, because that is where we struggle, is you can put all the homework in you want, but if you're just jumping off with a parachute, you don't know where you're going to land, you're on your own. That's the sense I think that people get. And that's our job, is to improve that. I think part of the transition is the education. There are a few studies, actually, I came across a few just published this year, saying a lot of that work that shows different questionnaires or other things to prep work are really based on healthcare outcomes that are important for a healthcare system, like readmissions. They're not actually as directed towards that patient-centered outcomes I talked about before. They're not directed towards self-advocacy And they don't always match up either. Some people who score really well on self-readiness and self-advocacy still have a lot of ED visits. It hasn't changed. And so I think it's more complex. And I think it really takes increasing integration across the adult and the pediatric spectrums, regardless of the centers, to work together. And I think that is an area where in the Twin Cities, I think we do all right at. We have room to improve, but it's one of the biggest challenges, because it is really like talking two different languages with providers who don't have the experience on the other side.
You know, and this is, I'm not sure, tell me, is this something that's talked about in medical school, about transitioning patients into adult care?
Generally, no. I would say that is probably changing to some extent, in the same way that certainly at the university here, there's more true integration of diversity, equity, and inclusion types of topics into our curriculum. So I think it's there, but it's a very small part. Yeah. And so it is really, quote unquote, on the job training that people have to provide. And depending on their interest or pathway they took, not everybody has a combined medicine and pediatrics residency like the University of Minnesota. So they may not even be exposed to people who do what I do. Now,
back up, explain to us what that means, that med-peds. Tell us a little bit more about that.
Yeah, so a little behind the scenes for medical training. Once you do medical school, you go off to residency. And so you're a doctor, but you need to do this extra training. It's required. And at that point, people generally go into either a surgical or a non-surgical field. And oftentimes it's pediatrics or medicine, medicine being basically 18 and older. But there are programs and those are each 3-year programs. And then you can specialize after that or be a generalist. There are programs, in the University of Minnesota has one of the larger ones, which we call med-peds. And so we actually do 4 years, but we do 2 of each. And we flip-flop throughout that training, but that training is really guided. I wouldn't say explicitly built towards it, but it's pretty clear that transition age group is a hot spot for people who go into this field. And so I think we spend a lot of time in our training doing that. But at medical school, you don't get it. And if you're in either pediatrics or adult, you may not get it to the same extent. And so some of this is exposure, and the lack of exposure means people aren't attuned or equipped to help with that transition as easily.
Well, let me just remind everyone that you can use your Q&A button to add any questions that you have as we continue this discussion. But, I had a conversation recently with during one of our sessions with a primary care doctor. And one of the things, we talked about a lot of things, but one of the things that we talked about is it's not, sickle cell disease, there's not an encyclopedia of knowledge in medical school. You actually write the encyclopedia after you get out, and it's only the experiences that you have that are writing kind of your encyclopedia of knowledge. And so understanding that if you are leaving pediatrics, where you were not introduced to that because you chose that, your parents chose that, and it's pretty much all you know. Chances are you started engaging in the healthcare system at birth or very, very early on. And it's all you knew. They almost became an extension of family, right? Because I think some of the challenge is that these are people you've known your entire life, right? The only other people in your life that you've known your entire life is your family. You can't deny the attachments that happen because of that connection so early on in your life. And then to transition, into a whole new medical team that's not a family, right? It doesn't feel like it felt. It doesn't feel warm and fuzzy, and there's not rainbows and unicorns on the wall. And, I didn't get some bubbles when I came in, right? Those are real things. And though you might not say, yeah, I don't care about the bubbles, there was a feeling that came with that, right? But it is the foreign feelings that come when you have to start new relationships. And I'm leading up to something, because when you're building relationships, you do so because you find someone who's a good fit for you, right?
Mhm.
And in the medical world, many times we call that a consult. We call that we go to different doctors. If you need surgery or you've had an injury and you want to hear other expert opinions, but you want to find somebody that's going to work well for you, you have a consult before you establish care with that doctor. But the reality is, when it comes to sickle cell and too many other chronic illnesses, that's the stigma is called doctor shopping. How do we overcome that? Like, that is a double standard that kind of creates a really difficult start for people during those transition years. Is it that what they're looking for, the expectations of what they're looking for isn't there? Or is it that they are looking for someone that is the right fit for them?
I would say that it's probably the latter. It's, and I think that we as medical providers are getting more attuned to that. You're right that that stigma of doctor shopping is there, unfortunately, and it's something that I certainly try to combat as much as possible. And it's not even just who do you find as an outpatient, and that's in reality sometimes the case for people going to the emergency department. They're trying to find someone to treat them appropriately. I think the biggest thing is, if you're transitioning, is lean on your adult hematologist or your adult provider, because the other reality is not everybody has that hematologist. They tend to be in urban environments, but there are but obviously hundreds and thousands of people with sickle cell disease don't live in those environments, may not have that same access to care. Lean on whoever your pediatric provider is to find who they trust, or to know where to send you next, at least as that starting point. It doesn't mean it has to be your perfect fit. I know I've met with patients and what seemed like a good encounter with me just didn't fit with the other person. And I said, that's totally fine, whether it's somebody within our clinic that is better fit, or somebody in one of our other, one of my colleagues around town. I just want to make sure that you are in a center that is comprehensive. There are data that show that sickle cell overall health and even life and death sort of scenarios are better. People do better if you're in a center that has some degree of comprehensive care.
And by comprehensive, you mean kind of a multidisciplinary, so many different types of doctors that are specialists in different areas?
Yep, exactly. So it just means having somebody where there's a hematologist and a nurse that works with them that knows sickle cell disease. That is not a guarantee. I am guilty of taking that for granted, but actually I'm working with national societies to try to figure out how can we train internists who are interested in this, because we just don't have enough hematologists either to do sickle cell disease. And so it's more about having somebody where they will have at least a social worker, perhaps a nurse, maybe another provider, but a core center where they can provide regular communication. Ideally, communication with the emergency department that is going to be utilized by that patient, because it's the communication gaps that I think are one of the biggest issues, and I think that's why we get, as hematologists, sometimes get frustrated if somebody goes to the other emergency department. We don't take it as a slight against us. And realistically, I would say, I'll speak for myself, I don't see it as doctor shopping any means, but it tells me that, okay, there's going to be a communication gap because that center has never been in discussion with me, or you're seeing a provider who may not be able to see my documentation, putting you at risk. And so it's that communication loop, however many providers it takes, that I would say is a comprehensive center, because then you can actually get to those specialist referrals, but more importantly, the core hospital team and the outpatient team can actually communicate effectively.
Okay, so I think that's a good segue to one of the first questions that we have, and that is, are there any examples around the country of PED AYA, and I think that what they mean is the Med-Peds adult lifespan transition, that you look to for a good model to follow?
Yeah, so it's a great question, and it's something that is continuing to evolve in the sense that, like I said earlier, there aren't a whole lot of providers who actually do themselves lifespan care like I do. There are a number of places, particularly in big urban centers, that have the pediatric center with the adult center. And in reality, there is not just one way to do this. You're in some ways your care model is dictated by where you live. So some of the places that have done really well with even just adult care, but adult leading into that, there are places like Hopkins, which has kind of in Baltimore, which kind of has a co-located, and University of North Carolina and Duke have that same sort of scenario where their pediatric and their adult centers are near each other. University of Alabama, Birmingham has a very nice co-location sort of model. But it doesn't have to, it's more about the most successful programs are programs where even if they don't have somebody like me, they have somebody that has the pediatric hematologist and the adult hematologist are in regular communication. The transitions go smoothly. And theoretically, you get to meet the adult hematologist before you actually make the jump to a different clinic. I think in the Twin Cities, we have a unique center, and for all of the seminars and conferences I've gone to on this topic, I say, our situation is different. We have this, primarily this kind of triangle of centers where you have a very large pediatric center in children's. You have, on relative terms, a smaller program under me, but then there's a splitting off because the children's doesn't have the same central adult center. So then they send either to the university or to Hennepin Health. And Hennepin Health and the university have pretty similar sizes and growth in both. But that asymmetry across systems is a big challenge. It's a communication gap, like I just talked about, that we have to do it. So my colleague at Hennepin, or colleagues, I should say, we do the extra effort. We try to make sure that we are in communication with children's before people come over. If they're coming from my center, it's easier because they're within my medical record, but it's a challenge. And so I think to some extent we can lean on those other programs, and to some extent we have to think on our feet and be a little bit creative, because there aren't a lot of cities and metros that are situated like ours.
And you're right. I mean, we are unique. Minnesota's unique in lots of different ways. This is just one of them. I was born and raised here, so I can talk about Minnesota. Anybody who's not, you can't. But what I almost hear you saying is that one of the solutions to transition begins in pediatrics. So number one, I heard you say a few comments back, it's got to start young. Don't wait until it's time for transition to begin talking about it. And I would go an extra step and actually say, when I was on the medical team in the pediatric setting, like, this is a conversation that starts when they are still very, very young, like toddlers, like their early school years, because I find that not only will you eventually have to transition that warrior who lives with sickle cell disease, you have to transition the mentality and the emotional capacity of the parents. Right? I mean, because I just personally, as a person who had a child with sickle cell disease, who knew very little about it, and what I did know was so much doom and gloom, you become a fierce advocate for your child. You become attached to their survival by any means necessary, right? Some people call us helicopter moms. Some people call us mama bears. So I prefer mama bear. I'm not as much of a helicopter, but my point is that transitioning it's a conversation that occurs throughout the early years to better understand that the system that you are currently in and getting care of will evolve as you get older, and how you move around that system will change. So is it fair to say that some of the biggest centers, and particularly like you said, where there is a connection between the pediatric and the adult side through the same system, is it because they have some sort of a program that is very, 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 very specific and intentional about that introduction early on, introducing them to adult providers, allowing the adult providers to come into the pediatric setting, allowing the pediatric patients and team to go into the adult setting. Does that address at least some of those concerns and those worries as you move over into a new system?
I think it does. I will say I've actually had more patients of very young, infants essentially, starting to ask more about it. So I would say there's a better awareness from a parent standpoint than there used to be. So like you were suggesting earlier, the younger the better. So that's part of it. I think there are reviews to try to figure out what works best, and I think however many number of studies, you have a different tool that works. So to some extent, yes, there are common themes. Having maybe a navigator to help is one, but I will say the navigators tend to be located on the pediatric side. So again, it's the homework side. There just aren't funding, if nothing else, for the adult side in most places. That isn't true everywhere. But some do questionnaires, some do other active engagement, readiness surveys, etc. Again, all on the homework side. Actually, one of the things that I've started to do more, and I think that this gets to generational providers and just really kind of evolving in my own clinical care experience. The parents are still there. The parents are, that kind of climbing up the hill to the parachute still suggests that they're off on their own. And in reality, we need to engage the parents on the other side more than we ever have had before. And I think that's a mentality I'm taking more. I think that's something that other people have, but that's not the mentality of people who have either only done medicine as their career, or sometimes the older providers. But I think if you are in certain centers, and I think our center is one, openness to change is important. And so openness to having parents, weaning the parent isn't the right term, but that kind of coming down the steps with the parents in hand for that theoretical warm handoff to adulthood that happens not at age 21, but maybe happens at age 23 or 24 is more critical. Because I know I've had a few patients, especially recently, where they're so well off because their parents have been that helicopter, like you said, and that's really important for me to hold on to, because that's going to keep them healthy. If they don't have that, that's where people fall through the cracks, because I'm not there every day, but parents usually are. It's very rare that they've moved out of their house at the same time they've moved out of their pediatric clinic.
Okay, Dr. Boucher, I'm a straight shooter. So let's talk about this, because you know what? I am a mama bear, and I'm a mama bear to many. But one of the things that I used to say is that I've never seen a cancer patient, child or adult, going through their cancer journey and not have their support system with them of all ages. Why is it that we expect that to happen in transition for people with sickle cell disease? And it certainly could be happening in other areas and other diagnoses, and particularly chronic health. But in this situation, there's this humongous push to make everyone independent. And I'm not sure that I believe that independence is the answer. I think interdependence, right? And some of that comes from a cultural viewpoint that says the community is your strength. We are nothing alone without the strength of those around us. And so I really like where you're going with this, because what you're saying is, who is your village? Who are those people in your life who have helped to get you this far, and who will likely help to continue your journey? Now, disclaimer, we know everyone doesn't have a strong support system, and that's a whole other conversation, right? Because we have to learn how to build our village if we don't naturally have one that's gone with us. But in the case of those who do have a village, and I don't care if your village is one person, you and your one person is a village, okay? But that support system, removing or leaving the impression that you are a better, more mature person if you leave this person behind or leave them out of it. I don't think that's the answer. I think it's about allowing the village to be a part of that journey. And to your point, it's going to happen at different ages. There's people that I know that transition at 18, some at 17. And then there's people who, you know, for lots of different reasons, don't really seem to wrap their head around the fact that transition has to happen. And they're still, you know, 23, 24. My son was 23 years old. And I remember him having a crisis. And he was like, take me to children. And I'm like, I can't. And I'm not. You're an adult now, and we have to figure this out. But the need, that sense of comfort zone that not only exists in the place you've always gone, but it also exists in the people you've had around you.
Yeah, well, to get to your first question, why does it happen? I don't know. I mean, I wish I had a better answer, and I think interdependence is the better term. I'll you know, in frankness, I wouldn't say that I was on the full independence bandwagon, but I would push for that more than I do now, because now I've learned that doesn't work as well. And so I've learned as a provider, and I think a lot of my colleagues have done it as well, and we start to espouse it more. We sort of focus on that, or at the very least coalesce the younger adult patients into a smaller subset of providers who can facilitate that better because of X, Y, or Z reasons. And so, you know, whether it's the younger providers or just more focus on that transition to a different mindset, because that's the part of the village, that small town village that I talked about. That's the part that comes with. The rest, right, generally speaking, gets left behind. And so I totally agree. Even if it's the village of one, it's a really critical village, and independence will happen necessarily, but it doesn't have to happen right away. And it doesn't, if it takes 7 years to transition, well, maybe it takes 7 years to be independent. I don't know. Everyone's going to be different, but it's worth writing that out and not trying to force something that isn't mature enough or ripe enough to make that jump.
Yeah, transition is a journey. It's not this one-stop shop.
Not a doorway.
It's not at all. Which kind of leads into this next question. Okay, got a question, and this is a parent of a adolescent with sickle cell disease. So talking about transition, my son is now 13 and getting more worried about taking hydroxyurea and Endari for the rest of his life. So what's the current position of gene therapy, which is my only hope of consoling him that help is on the way? So that's a very interesting question, a little bit out. I hear where you're coming from. Some of your answer may be embedded in other sessions that we've done and other individuals that I can connect you with, to the individual who wrote that. But Dr. Boucher, talk to us about that adolescent who is beginning to think about now their life as an adult, right? Is there is some of this an underlying fear of, you know, what will happen to me when I don't have the same set of doctors? Is some of it the fear of, am I getting closer to dying? Like, let's just put that on the table, right? The fear of death. Is some of this that, you know, I might not get cured and I have to live in this pain for the rest of my life? And like, you know, maybe it's all of those things, but talk to us about that young adolescent who's just now seeing life through a different lens.
Yeah, well, I'll first start with the question of the medications and the forever nature, so to speak, of it. It's a hard thing, and it's a discussion I have with parents, and early on, you know, when it's still an infant, those parents are also thrown off by that, even if we're talking like 20 years down the road. It is also in adolescence where we start to see, as is suggested here, that the teens are really starting to see that for themselves. And to the extent of the why, I think there's a lot of reasons why. I think some of them are what you just talked about. Is it starting to think even more about not in the day-to-day or the week-to-week or the focus on school or whatever, but now it's like, okay, there's life out there, and there eventually, whether it's I'm at 13 or I'm at 18, that transition's coming. I also think there's just something about taking a medicine, a preventive medicine, is just not something we're great at in the US because the lack of an outcome or the lack of something happening is really hard to wrap your head around, right? So if you do hydroxyurea extremely well, 95, 98% chance that, you will delay, to some extent, sometimes delay the inevitable, but certainly prevent or delay complications. And you say like, well, how long do I have to do that? Because nobody wants to take a medicine every day. And they've been taking it since they were 9 months old. It's not an easy discussion to have at this point, other than the curative therapies, the bone marrow transplants and gene therapy options. It is still the standard of care in adulthood. We are trying to figure out, we being collaborators in the US, and including in research trials, trying to figure out, can we better dose adjust hydroxyurea? So, because what happens is, it's usually weight-based through pediatrics, but if you keep doing that in adults, it starts to get to be a lot of pills. And insurance actually doesn't cover generally speaking, fights back on some of the 1,000 milligram tablets. And so you get stuck taking the 500 milligrams, and like nobody wants to take 6 tablets a day. We're trying to figure out, is there a way to actually use laboratory testing to figure out, okay, not everybody needs, it's not probably the best to put 2,000 on everybody, and maybe not everybody needs 4 tablets a day. Maybe some people need 2 or 3. And historically, we've just based on it on blood counts, but there actually may be better ways to do that for each specific person. But I think, that's a little bit in the future, but for the now, it is that, okay, you just got to keep taking it, and we promise you it's worth it. And that only means so much, because as much as we are part of the extended family, we are still extended family, and we're not living their day to day. And so I think it's just really important to kind of reinforce yes, it kind of sucks to keep taking it. And there is a loss of adherence to that plan as to adulthood. There are data to say that if you've been seeing a hematologist in the last year, you're more likely to take it after that transition. But it's hard.
The other thing that I would say about, that adolescent point, that they start seeing the world through a different lens. They start seeing their lives through a different lens. I can just tell you, just from experience, one of the things that really I had to be intentional about was connecting myself as well as my young adolescent with other people with sickle cell that were older, right? So that they could see that there is a life beyond just your diagnosis, that you are more than your sickle cell, that there are people who are living a quality life, that are still going to college, setting goals, that are meeting goals, that have families. We have individuals on the call that are adults living with sickle cell disease who have wife and children. And you know who I'm talking to, so speak up. But it's important to connect them to a village outside of just family, just medical providers, right? They also belong to a community of individuals who have been where they are, and can help to guide them from their own lived experiences. And sometimes I feel like, and I learned this the hard way. I'm not telling you this because I read it somewhere, or this is just what I tell other people. These are things I had to tell myself. I ain't the end all be all of the hope that he has for his future. In fact, I might be the opposite on certain days. And my son has no problem telling me, like, I don't want to hear your voice in my head today. And so the reality is that I had to take a step back and say, okay, how do I integrate him into a bigger a community where he can see other people like himself, who are living life to the fullest, and then removing this is such a key age, that 13, where they are really figuring out who they are in life, right? Their identity. This is part of a normal ages and stages, right? It's not unusual for a 13-year-old to be trying to figure out who they are, right? And who they want to become. So getting them involved in the community, and allowing them to expand their views beyond what they may currently have, I always think is very important. And in fact, you know, in 2022, we are working on starting support groups so that we can help to make some of those connections as well.
Yeah, and I think that just to add on to that, I think it's really important, like you said, the older view, but I think it's also important to sort of recognize that in some ways, when we are taking care of sickle cell in pediatrics, we're developing that kind of like the beneficial awareness, the self-reliance, et cetera. But sometimes that becomes a hypervigilance that becomes problematic when that becomes the living day-to-day of avoiding sickle cell complications or something else. And so it's really important to see that other community, to see people doing things, and the people who I find that have the most successful transitions, even with the health-related complications of sickle cell, whether it's a stroke or something else, they've got other features, or features of their life or support systems in their life, or just things that they're doing. And actually that's informed me in a way that I've started doing with all my patients of, let's set 1 to 3 month goals, let's set 6 month goals, and they can't be disease related. They've got to be something that is outside of this, because you've got to live with sickle cell disease and try not as much as possible to be so focused on it to the detriment of doing everything else. And then a metaphor that I've started using more is this, how do you get up the mountain? Do you climb up with a wheelbarrow, or do you climb up with a backpack? If it's sickle cell stuff in a wheelbarrow, it's difficult, it's imbalanced, it tips back over, you got to start at square one, and you can only do it yourself. So it's really difficult, both hands on that wheelbarrow, and it's heavy and it's just unwieldy. The other way it would be doing it is carrying it as a backpack, because you could carry that load with other people, for one. Your hands are free, your view is free, and you still know it's a burden. There's no question about it. This is not to understate that effect, but it's to say you can do other things with that. You can climb that mountain and see other things, because you're not so focused on keeping the sickle cell wheelbarrow in balance to the detriment of doing anything else.
You know, and I love the way that I love the metaphors that you're using, right? Because I think sometimes that allows us to see it through different lenses and perspectives. And, you know, it is this delicate balance, because no one wants sickle cell disease to be their identity, but we also don't want it to be on the back burner where you ignore it and act like it's not there, right? But finding that balance of how much attention does it deserve, should it have, without allowing it to be the deciding factor on how you set goals in your life and what you want to attain, right? I personally know of individuals that are that have sickle cell disease, not even just trait, that are researchers, that are flight attendants, that president of an HBCU, they are thriving, lawyer, you know, so I know someone in that is a representative in Congress. So they are out there and they are doing incredible things, and we have to be very mindful that we don't find ourselves subscribing to what oftentimes happens in our society, where we hyper focus on all the negatives, and we forget that we don't hear about the positive, because the positives are going on living their lives, right? So what shows up in front of us is oftentimes those more challenging situations, but they don't define all of the situations. There are more than, we believe there are more than 100,000 people in the United States living with sickle cell disease. The percentage of people who regularly end up in the hospital or have some of the most concerning complications is in comparison, those who are doing well deserve more attention so that we can see that hope. And quite frankly, when you see those who are doing well, even if you're not, there's something that does inside of you that really kind of instills a sense of, wow, if they can do it, maybe I can too. And so we have to remember that you know, those individuals who are quote unquote living well with sickle cell, some days I like that term and some days I don't. But how do we get them to speak up more? How do we get them to talk? I see that we have a comment from Demetrius Scott, who lives with sickle cell disease and is in his 40s. And he says, I've been speaking with the National Football Players and National Basketball Association, right? This is about making sure that we are spreading awareness of all the things that we can do, while we also talk about the challenges that we live with. But we have to get the word out so that we're not just preaching to the choir, but we have to make sure that people who are living well, going about their lives, are seen as valuable contributors to the sickle cell community as well. If there's anyone else that's living with sickle cell disease, or if you're a provider, we want to hear from anybody and everybody on the line. Tell us what your experiences have been with transition. If you'd like to speak out loud, we can certainly open up the mic so that you can do that. Just let us know in the chat box. Let's see. I'm also curious about the pandemic. How has the pandemic changed transition? How has it impacted transition?
So I think in one sense, it's sort of put everybody kind of in that same boat of reevaluating their own health and taking stock of what's important. And so I think as I've seen with patients in transition coming to me new, more of them have talked about, you know, or it's easier for them to be thinking about this question of what are my next goals, because they say, like, I've had to think about that with COVID, or I've had a couple who have had multiple family members die of COVID. And so it's really caused them to take stock in their own health. So in some ways, it's a negative that they've turned into a positive, which is a huge value in and of itself. I think from a transition standpoint, it forced us for a long while to do more virtual visits. And I will admit, and this is something that I've started to study here, not just within sickle cell, but within our cancer care clinic, is I figured it might be a perfect fit because, you know, a lot of transitional age individuals are tech savvy. They don't always want to be in the hospital, et cetera. But actually it was the opposite. I found a lot of people who said, I don't want to do this virtual. That connection of being in person is really important. And that was eye-opening to me. And it was really valuable because telehealth had been kind of on the radar before the pandemic, and then we got forced into it of, hey, we need to figure out who does telehealth work best for, because it doesn't work best for everybody. Mm-hmm. And I think for the transitional group, particularly when you're meeting somebody new, and you talked about it, you're going to a new family, it's maybe best case scenario, it's like in-laws you really like, but it's not the same family. Meeting them in person is different than meeting them on Facebook, right, or whatever. And so that connection, that ability to build that relationship with their new provider in person, at least the majority of the time, was really important for most people. So that was new with the pandemic.
Yeah. And you know, I remember, I mean, when the pandemic started, I was still working on the clinical side as well as the foundation, but that was one of the most difficult pieces, because we had people that, you know, were at the point of transition, and it's like we understood the value of the relationship building process, and that was like a huge kink that was trying to help these individuals who are already nervous about leaving the pediatric setting, and going to see people that they didn't know, on top of the fact that, you know, I fully support social media and many of the groups that are in existence But the reality is that not every group is a good group. Not every conversation is a great conversation. So sometimes, you know, you can read through these posts that are in some of these groups and you feel more a sense of defeat before you feel a sense of hope. And so really having to come up against the fears of what was going to happen in transition before building the relationship really impacted the building the relationship piece, and then doing so over a screen is just not the same. So I'm so glad that you all are back in person. I want to acknowledge that we do have providers on the line as well, because I think that this is whenever Sickle Cell Foundation of Minnesota talks about community, we really want to change the narrative that community is only patients and caregivers. Community is people who care about the outcomes of sickle cell disease. We are a much bigger community than I think what we sometimes give ourselves credit for. And we have to remember that whether you are a provider, a medical provider, whether you are an educator, if you are focused on making things better for this population, you are part of the community. We don't want you on the outside looking in and saying, oh, what can I do for them? We want you on the inside reaching out and saying, how can I continue to help us, right? There's a different sense of responsibility when you talk about it through that lens. We want you in that, you are part of the inside of the house. And even though we don't see you as often, and as we talked about, you know, this extension of family, I don't know about your family, but my family ain't gonna be knocking on the window talking about, can we come in? No, you are in. And so being able to bring all of the community together. We have a representative from Be the Match here as well, with bone marrow transplant and providing resources. We have other individuals from other industries that are here, even from industries that make medications for people with sickle cell disease. Why? Because it matters. It matters what are the challenges, but also what are the wins, what are the gains that we've had in many of these areas that we continue to talk about. We have to be able to celebrate our victories as we continue to embark upon these challenges and find solutions to these challenges. If you know Ray, you know that I am a solution-oriented person. I'm going to turn whatever it is around and try to and really look for ways to see it through a different lens and redefine it so that we can remain positive in finding solutions. Some are harder than others, but transition is one of those things that I think is one of the first fears that individuals feel when living with sickle cell disease. And frankly, I call it the trifecta, right? It's not when they transition, it's much like our guest asked, it's when their eyes suddenly open to this different view of life. And I call it the trifecta, meaning that there's three things that are happening. You know, number one, you see the world differently. And let's be honest, as individuals living in Black bodies, the world sees us differently as well as we get older, when we go from that little cute baby into that our own person, and how the media often portrays the Black community. We see things differently, and unfortunately, some people may see us differently. So that's one of the pieces. But then we also recognize that we are getting older. Right? We can't not have a birthday. We can't stop the clock from ticking. You can't do anything about that. So I always tell people, you can't stop being Black. Every time you walk out of your house, that is who you're going to be. How do you become comfortable in that skin, confident in that skin, and yet understand how to navigate the world in front of you? You are going to continue getting older, not me, but all of you. But you're going to continue getting older. The easiest thing to put on the back burner is the third part of that trifecta, your health, right? Because those other two things are really big deals to be dealing with at that age where you are trying to figure out, who am I? What do I want to do? What do I want to be? The last thing you want to think about is your health. So I'm really not surprised when a 13-year-old young man is like, do I have to do this for the rest of my life? Because in the sense of all the things that they are now seeing for sometimes the first time, seeing through that lens, I don't want to think about my health. I already have to think about, racial issues. I already have to think about age issues. And what am I going to do in life? How am I going to pay rent, right? Adulting, like, let's just call it out. And so it is easy to put that on the background, and it is easy to feel an overwhelming sense of fear that comes with any one or all of those things at the same time. So I appreciate that we talk about those things openly. My question would be, if you were talking with a pediatric provider who wanted to understand how they can continue to shape their practices around positive transitioning, what are a couple of key things that you might share from an adult provider perspective? And I know those can be hard discussions, but that's what we do here. We talk about hard stuff.
Well, I think one of the things would be actually to invite them into the clinic and see, sort of the flow of care for our side on the adult side, because I think that's the hardest part. And I can speak to that as somebody who was doing a lot in the pediatric care before, without a good adult transition and training, is you don't really know what's on the other side. You can try to predict as much as possible, but it's not really the same as seeing it, which is probably as close as they're going to get unless they actually are doing the care. But the other side is the continued discussions, the openness of what's working and what doesn't, collaborative meetings on transitions ahead of time with enough lead time so that the adult side, we can do the recipient part of it smoothly. And because the shorter the gap is between that requirement to leave the adult or the pediatric side and to the adult and getting into the adult clinic, the better chance we have of keeping people in the system and continuing to be as successful as they were for the many years in pediatrics. The pediatricians and the pediatric hematologist do an amazing job keeping them healthy, so that 96, 97% of individuals with sickle cell disease get to that adulthood. So that they put in the hard work, and I think it's beneficial to continue those discussions so that their hard work pays off.
I agree. And it really is a partnership that has to occur and that continues to grow. We do have a provider. I love it. Melissa Claire, who is with Children's Minnesota. She is a nurse practitioner, so an advanced practice nurse, that says, in my experience, I have found that ensuring AYA patients are empowered through education has been a successful tool. Knowledge is power, and being equipped results in respect and encourages them to be active participants in care. It's also a power differential equalizer. That's a powerful statement, right? We know education, I am a firm believer. Education, knowledge is power, and the absence of knowledge is oppression, right? That's a saying that my old team knows that I've said it a million times, right? And so the more information that you give people, the more that they can make informed decisions and be empowered in how they develop their quality of life. But when talking about that power differential, let's talk about that, because there is a power differential, and then we're going to wrap up. So if you have a question, get it in there. That power differential is really part of the healthcare system. And I can remember, like, if y'all heard me tell my story of how I ended up where I am, I was not the most liked parent when my child was young, okay? I know that might be hard to believe. Okay, not really. But here's what I'll say. I was never that parent that came in cursing everybody out up one side and down the other, but I asked a lot of questions. Now, this was back in the late 90s. There was still a patriarchal mindset. It was not patient family centered the way that it is moving towards today. And so when I would ask questions, there would almost be this gasp of, well, we already told you this is what we're going to do. And I'm like, but I need to know why. Like, I need to be able to take my understanding of the why and explain that in terms that my son can understand, so he understands why we are sticking him for the fourth time today. And it felt I just remember many times that I felt like the people who hold the power over me are also the people who won't let me feel empowered. So that knowledge, let's talk about that power differential equalizer.
Yeah, I think that it's really important, like Melissa said, to encourage that open communication. And one of the things that I do in my clinic at the very first visit, I say, I recognize that structural racism is inherent in our system, and we have it at the university. Everyone does. We're going to try to attack it, but I want this to be an open and a safe forum for you to tell me about that. I want you to call me out if you feel like I'm being biased or racist or in any other way, because that's not my intention, and I need to know if that's the way I'm coming across. And I need to check myself if that's the case, because I know that I'm going to be, if I were in the emergency department, I'm going to be treated differently than the person sitting across from me. And so we try to do that. So it's not only just the knowledge, the passive knowledge that has been gained, but it's the active ability to talk about it, to have that opportunity to say, hey, my emergency department or my hospital stay didn't go well last time, and this is why. And to have that as a safe space, because then I can try to address it and encourage not only just as that second or third hand, but then, particularly young adults, to have a voice in their care as a system. Those are incredibly important, because that takes it just from, hey, I know what sickle cell disease is, to, hey, I know how the system is treating this disorder, and I want to make it different. And so those are the things that we do to help equalize that power in very much the same way Melissa said.
Yeah, and I love that. I think that, I'm a huge proponent of the why, right? And better understanding, and I'll even use some of this response to the father who asked about his 13-year-old, talking about the why we do things, why this is necessary, why this benefits you, and framing it from, when you better understand this is the why, this is what allows you to be able to set these other goals and to do this and accomplish this. I want to touch on something that, you may not have spoken broadly about, but one of the first, what you do in your first visit is you want to get to know that person, not their sickle cell. Who is the person sitting in front of you? What are their goals? What do they want to accomplish in life? What does quality of life mean to them, right? Not just focus on all of the challenges that make it difficult to reach all of those things, right? Because that changes the way you think about life, and you think about getting up every day, and you think about the challenges as they come. You are focused on the outcome that you want versus passively accepting the outcome you may be getting, right? And I think that that's an enormous mental shift that is part of the empowering nature. And when you understand the why of what you have to do in the medical sense, what you have to do in the education sense, what you have to do in the community sense, right? You learn different drivers of how you're going to attain quality of life. And so I appreciate that question and having that conversation. And I appreciate providers like yourself who are willing to say, hey, we know that there are extreme and exorbitant challenges that just simply come with living in a society that it has so much structural racism. And we as a society, and at least my team or myself, is learning how to push back against that system that where we've assumed something is right that might not be. So I do think that open, safe space, right? We've talked about that before, having a safe space to be able to have those conversations and giving someone the freedom to be able to have that conversation is so very important from the beginning. Don't wait till the situation's on fire to have that conversation. You have it before there's smoke, before there's flames, and that way you kind of level that playing field.
To say, I think it's important to do that, to sort of the psychology of kind of priming, to make that safe space also the place that we're getting to know people and taking the focus always often, away from some of that continued, sort of seemingly always negative sickle cell part of it. Because then you know that when you're coming to clinic, we're going to have a human-to-human conversation. We're not just going to have a doctor to sickle cell personified sort of talk, because that is never ultimately super productive unless there was a really acute issue. But otherwise, it's really getting to know people and building that trust. And so that trust of getting to know who they are as a person with sickle cell, a warrior living with it, allows then also that ability to have the safe space to talk about the difficult topics that I need to know about, to hear about on a regular basis.
Well, I love it. And I love these types of conversations. I'm so grateful. We could talk all night, and I'm good for that. Ray is talkative. But I want to just give one more response that was by Dr. Derek Gabeau, who is a hematologist, and he is the director of the sickle cell program at Children's in Minneapolis, that just says, thanks, Ray and Alex, for a great conversation tonight. Look forward to our continued collaboration in providing these patients and families with the best care and outcomes possible. We are partners. We are a community. We are all in this together. We all care about the outcomes. So whether you're in the medical system or whether you're in the community setting, we have to begin to link arms and find our strengths in one another, improve one another. There's always room to do better and be better, no matter who you are, who I am, who anyone else is. And so we'll continue to make that a priority as we move forward. I am so grateful to each of you for joining us for tonight's session of Living SickleSMART. I'm going to do one last share screen so that you all can see what we have coming up. As I said, we are grateful for you joining us. This session will also be available on our YouTube channel, the replay starting probably tomorrow, because I'm hungry and I want to go eat. So starting tomorrow, but I also want to make sure that you guys know I have a really exciting panel coming up for our December session of Smiling Through the Pain. We are going to have a live warrior panel, y'all. We've got 4 incredible people with 2 co-moderators, myself and Velvet Brown. She is a licensed social worker out of Oklahoma. She actually runs the Supporters of Families with Sickle Cell community-based organization there in Oklahoma. But we are going to have another open dialogue. We want you to join us. Sign up via our Eventbrite channel. We also have an event page on Facebook as well. That's just going to take you back to Eventbrite, so you might as well follow Eventbrite. And don't forget to sign up to be a subscriber to our YouTube channel. Okay, this is petty, but we can't have a specialized name for our YouTube channel until we have a certain number of followers. So we need y'all to come on, follow us, please, subscribe to our channel so that we can customize our channel the way that we need to, so we're easier to find. And then last but not least, we did have a session earlier today that is now available on-demand webinar, Navigating Primary Care. This is also an important piece of the transition conversation. We had a conversation with Dr. Hannah Lixon of Hennepin Healthcare, who is a primary care doctor. So you can find that on our YouTube channel as well. And then we also have a session that we did last month on the educator and caregiver perspectives on individualized education plans, or IEPs, IHPs, which are individualized health plans, and 504 plans, y'all. We got individuals who are actual educators, and one of which is actually a warrior mom as well. So you want to check that one out. And then just a reminder to get your sickle cell warrior resource package. Go to sicklecellconnect.com, order one for yourself. If you're a provider, be sure to share this with your patients. No shame in my game. I'm going to continue plugging this until we see sustainable differences. There is a cure for sickle cell disease. It may not be available to everyone, but it is available to some. But that cure is only as good as the number of people on the registry that make a good match. And frankly, let's just be honest, there are not enough people of color, specifically Black and brown people, on the registry. We need you to sign up. Join the registry. be the cure, because we are the cure. And then last but not least, if you really want to lend a hand, lend an arm, donate blood, because it does save lives. Donated blood and blood transfusions is a huge piece of what keeps people healthy in the hospital, and oftentimes can be life or death. And we are at unprecedented challenges in the blood supply. So anytime there is a challenge in the blood supply, we know that there is also a challenge in finding the best matches for people of color, and particularly people with sickle cell disease, who after many, many transfusions need to make sure that that match is as close as possible. So we do invite you to donate blood and join the registry. Until next time, we will we'll sign off for now, and then we will see you at our next Living Sickle Smart. We are excited about our 2022 series, and you'll hear more about that in the weeks and months to come. Please continue to join us, continue to support us. We appreciate you all. You are our community. We are yours and you are ours. We're stuck together in all the best ways possible. So be blessed. Thank you for joining us. Signing off.
Thank you, Ray.
Thank you, Alex. 1 second, Alex. Do not log off quite yet.